Thank you very much, Chatty. I think, these discussions of stent geometry and thickness recapitulate a lot of what we talked about back in the day of bare metal stents, and as we moved to drug-eluting stents and trying to understand why there were differences in outcomes and weight loss. And it was, some relation to the amount of metal as a ratio of the size of the blood vessel, so it's not surprising that thinner stents might do better in smaller blood vessels. But I think we've gotten to the point of stents that they'll perform very well in getting to the artery, but there are other trade-offs when we get to thinner struts, and I wonder what the panel thinks if there's going to be a lower boundary of thinness. Are there trade-offs in radial strength and the ability to see the stent? And are we going to run into problems of longitudinal deformation? You do complex procedures. I'm always worrying about messing things up with the guideliners and the guiding catheters. And should we only be focusing on the thinness of the stent strut, or should we be thinking about optimizing deployment in the first place with imaging, and maybe that's a more important aspect than 10 microns? What do you think? What do you guys think?
So to address a couple of those points, I think certainly with some of these changes towards stent strut in particular, there's going to obviously be a sweet spot, I would think. And eventually you're going to be limited in how thin you can go in terms of your recoil of your stent, especially in difficult lesions, heavily calcified vessels. So I think that would be to be expected. So it's about finding that balance. In terms of other factors, I was assigned that debate topic the other day, basically to say that all these technologies are the same. But in looking into that topic, it caused me to think a lot about the other things that we do that actually have a much more significant impact on the procedure. And I think, as you alluded to, imaging is absolutely key. You're looking at cutting your TLF and MACE rates down. Hazard ratio is 0.5, absolute risk reduction 3% or so. So I think that's quite important. Maybe more so than some of these small changes in the stent technologies.
I agree with you, Dwayne. It's similarly, now with doing more complex cases, you see calcified, you do a lesion modification, but the deliverability of the stent is important, as well as the radial force, as well as the patency down the line. Now we are doing more IVUS, especially in the light of ultimate trial. I think IVUS has been up and coming more. So stent opposition probably now is way different than before. So probably using the same stent technology with different strut thickness, probably not that different. As you said, thinner does not matter as much, but well-opposed stent delivered to the lesion of interest and covering the whole lesion, probably that's more focus compared to the focusing on few millimeter here and there.
Mm-hmm. Just to Allison's point, I don't know if people were there 2 days ago. There was this fascinating debate that Allison was DES platforms are the same versus not the same. And at least my take-home point was that with contemporary PCI techniques, intercorner imaging, delivery guidelines, really there's no major difference between the contemporary platforms. I think there might be niche indications, like I guess yesterday when we were talking about radiation and some specific situations in which you may want more radial support. But outside of that, the contemporary platforms are fairly similar.
Other comments?
Well, what about eliminating the stent struts at all? Is there any, do you think that with all these advancements, would there be any rule to study this against drug-coated balloons in the US? If the stent struts, we keep them getting thinner and thinner. What about eliminating them at all?
You mean in a bioabsorbable platform?
In a drug-coated balloon.
Yeah. So I think that's a very interesting point just for the audience to hear, is that would we primarily treat arteries with drug-eluting balloons? I would take maybe a historical approach to that and saying that the initial lumen gain is the best predictor of TLR later. So if we were able to get a balloon that was able to get an initial lumen that was similar to what we could get with the stent, that would be great. And then also, too, Manos and I and others are probably still old enough to know about the cases that we always had to bring back for abrupt closure after their POBA procedure. So really one of the main benefits in the acute phase of stenting is to avoid abrupt closure and having to go back urgently. So I think the technology has to advance. I agree that it's going to be very interesting, the role of drug-eluting balloons in restenotic lesions. So maybe a quick poll from the audience in a non-technology way. Take your favorite stent. If you had to pick one thing to make it better, would it be thinner, bioresorbable polymer, or something else?
I would choose deliverability every time, I think.
Yeah, okay,
Yeah.
so would you take thin strut then, because it delivers better, or?
If it has acceptable elastic recoil properties, sure.
Okay. And let's add in visibility. Okay.
Yeah.
I think thinner is always better.
Thinner is better, okay.
I would agree.
Thinner.
Clearly the bioresorbable scaffolds didn't pan out, but I think with hopefully more innovation, I think it still would be a promising technology.
What
there's
about
a- if they're
bioabsorbable
approvable.
polymer? Does it make a difference to you?
I don't think it's that dramatic, but
Okay, all right.
I like thinner, but I think the most important point for me is imaging guided, like using IVUS or ACT, because I think this is one of the most important predictor of TLR or stent thrombosis. We did actually like an analysis of left main PCI from a national cohort, and we showed like IVUS use was only like 15%. So I think this is a huge underutilization of.
What about the audience? What do you guys think? Should we be fat shaming stents? It seems like everybody wants the thin struts, you know.
I was just going to make one small point about the discussion earlier about just using balloons or drug-coated balloons. While I don't think that should replace stenting, obviously, with the new P2Y12 inhibitors, image-based PCI, et cetera, I think there is potentially more of a role for using some of those technologies for some of the edge-related issues that we have for dissections and complex procedures, those kinds of things. I think it came up in one of the live cases during this meeting as well. So.